for Medicare for 2017, modified by me. So first off, the numbers. Who's all enrolled? Medicare is a huge, it has a huge coverage for people across our nation. It's a huge dynamic in determining healthcare rates and provider availability within, or who they're going to work with and what rates they're going to charge. It's a huge player in that game because of the population of people that are enrolled in Medicare. There are 57.7 million people enrolled in Medicare across our nation. Some are because they have turned 65 and are eligible for Medicare. Others because they are disabled and been on Social Security disability for 24 months or longer. That constitutes a long-term disability according to Social Security. Once they hit the 25th month, they are automatically enrolled in Medicare, and that would make the total disabled population that's enrolled in Medicare 9 million people across our nation. Let's see here. There are a few exceptions to that 24-month waiting period. That's for end-stage renal disease or permanent kidney failure, otherwise Lou Gehrig's disease, also known as ALS, commonly referred to that. So those are more of a fast track to get into Medicare. They don't have to do the 24-month waiting period. The reason for that is they're considered a more faster, progressive, higher cost medical condition. Now, you're probably like me thinking, I know of a lot of other fast progressive medical conditions that cost a lot of money, but for whatever reasons, just those two that are the exception to that 24-month waiting period. With that, you'll see that 19.9 million people are enrolled in Medicare Advantage plans, so just a slim population is. And then Part D, there's 52.3 million people enrolled in Medicare Part D for prescription drug coverage. A lot of people, maybe there's people who are utilizing their VA benefits to get their medications, or maybe there are people who are on an employer plan that are using those, or maybe they have a retiree plan, or maybe they just pay for it out of their own pocket. But that's the reason for the gap, the 15 million person gap there. So this is South Dakota's. This is one of my slides I've added. South Dakota Medicare population for 2017. And of course this number is a moving target. There are people entering, aka turning age 65 or meeting that 24-month disability waiting period. And there are people passing away. So it is a ebb and flow type number. Medicare population in South Dakota is 162,000 plus people in our state are on Medicare. 18,986 people are on it due to disability. And in our state, we have 32,694 people in Medicare Advantage plans, making up 20% of the people who are enrolled in Medicare. So about 20% of our people are on a Medicare Advantage plan. A slim portion, just like the national statistics are pretty close to that too. Some changes that we've heard about. Some of these are going to be a repeat from last year, a new update maybe here and there. Some are going to be new, and yeah, some are going to be a future thing like this for 2020. But we want to make sure you have a good idea of things that you hear in the news, what they're talking about, and how we foresee it impacting our Medicare beneficiaries in our state. So with this MACRA law that was passed that helps Medicare and Medicaid save money, there are a few different changes that have come across due to the MACRA law, and that's all labeled with this MACRA symbol here. One of the major changes to Medicare beneficiaries was they're changing the income thresholds for those who have higher income. They would pay an increased premium for Part B as in boy and Part D as in dog. So those who have higher income would pay additional premium for those two parts of Medicare. Starting in, and that's already started. That started actually quite some time ago. I think back in 2008. It's been a while, maybe before then even. But they have increased those thresholds, as well as starting in 2020, they're going to start applying a cost of living increase to it. Now here's a good visual. So this is anything prior to 2018. This was the income threshold. This has been this way for probably 10 years plus. Anybody who made, this is individual, an individual who made $85,000 to $107,000 a year paid 35% of the Medicare premium. So we're all subsidized a little bit. Nobody pays 100% of what Medicare Part B actually costs. It's all subsidized by the government. But these people pay a higher or a less subsidized amount. Does that make sense? They don't get as much of a break. So, and then those are the thresholds. Well, starting in 2018, coming up here very soon, they're shifting these thresholds. So the first tier, that's remaining the same, but you'll notice down here, anybody with more than $160,000 of annual income would pay 80% versus prior to that, it was, let's see here. Yeah, it was right here, 65 or more. So what it's doing is more people are falling into these thresholds. They're shifting it so more people are going to be paying more money. And
individual income or like married income?
This is individual income. The married income is times 2 of all these numbers.
Oh,
and it is located in the book, the training manual, as well as Medicare.gov too. Yep. So yeah, people at the state don't need to worry about it, but it is, you may hear of things if maybe they sell off their land. We do hear of this in the rural communities. They'll sell off their land and then all of a sudden they pay way more for their Medicare Part B. Those things you may hear about, and that's due to this. If you've seen a change and it's really confusing, that doesn't even make sense to me. It's probably due to this, especially those temporary cases. And then, just to clarify what I said on the prior slide, starting in 2020 here, they're going to start adjusting these thresholds by a cost of living increase. So they're going to be changing each year then, from then on. Because these have stayed the same, like I said. These numbers, prior to 2018, those have stayed the same for a long time, like 10 years. So they have not been adjusted for inflation at all. So that's going to help keep more people paying the more premium too. Yeah, good questions.
What percentage does somebody that makes under $85,000, what percentage do they pay?
I'm pretty sure they pay 25%.
Oh, okay.
Yeah,
That
so
134 is considered 25%.
25% of what Part B really truly costs.
Okay.
Yeah.
Wow.
Yeah, and that's the thing that took me a few years to catch on to that. Yep, good questions. So part of the MACRA rule is protecting Medicare and Medicaid, that kind of a thing. One of the major projects that they have decided to undertake with this law is to change up the Medicare cards that currently have Social Security numbers as the identification number for Medicare beneficiaries. It's been kind of the master key. It could be used for identity theft, financial fraud, Medicare fraud, healthcare fraud. It's the AKA master key to people's identity. So what they're going to be doing is changing not only that number, it's still going to be an 11-digit number. They're using 11 digits, but it's going to be randomized of letters and numbers. So it might be 1, H, B, C, 14, 75, whatever, 11 numbers and letters. And like before, you used to be able to tell. If it had an A, it was for that individual's, based on that individual's Social Security record. A B would be their spouse's that was following it. They're not going to be intelligent numbers, which I think is the dumbest wording, but they're not going to be intelligent. So you can't tell whose record they're drawing it off of or that kind of thing. So it's going to be very random. Let's see here. They're going to start this in April of 2018. So actually pretty soon. Yeah, it's coming up. Providers are supposed to be having their systems compatible right now. They're supposed to be ready for this change. Nobody knows what these numbers are. They're trying to beat the fraudsters on a variety of aspects. So they want to make sure that things are secretive enough so that fraudsters aren't able to pre-plan and develop a really good game plan to confuse Medicare beneficiaries. So they're trying to keep things a little bit quiet, but yet, the same breath, educate people so that they can guard their card and try to avoid misunderstanding this major process that's going to take place. In addition to giving everybody who has Medicare a new card, they're going to be giving new numbers to those who are deceased or archived records. I just hope and pray that they don't accidentally mail those out, because that will cause a huge major confusion. And all of us who work with the federal government in some capacity, that really could happen. But we're going to just hope that they don't make a mistake. So, you know, they're also issuing those numbers. So people in a transition, maybe someone passes away, even now, they could be settling health care bills from a while. So there could be a little confusion with that, too.
Why are they doing it to the archive ones? I mean, I guess somebody who dies recently.
I think because there's a huge problem with people billing deceased people's Medicare numbers. And Medicare is not set up to be, you know, I'm going to investigate each claim. They're set up to be super fast for providers, so providers want to work with Medicare. So they pay it first, and then they chase anything that looks weird. So they're trying to stop it all. And yeah, and I'm sure it adds a level of complexity I haven't even had a moment to think through or care about. But this transition period, so the distribution of these cards is going to go from April 2018 to April 2019. They're going to allow this transition period to go till the end of 2019. So providers could bill on either number. So somebody does shred their card because it comes in a very plain envelope with no markings, that somebody already will shred right as soon as they see it. Because we've trained them to do that stuff. If they accidentally do that, they have to get a new card. There's still a period of time to get this all sorted out, and they're working through the end of 2019. I wouldn't be surprised if they extend that. I wouldn't be surprised if there's hiccups and that kind of thing. But that's my speculation. It's not what CMS is saying. And then if you do have your Medicare number compromised, you would get a new unique number. So they are able to update that and change it if something were to happen. This is some things that I see as problems with this, is this transition period of April 2018 to April 2019. I'm sorry, it's not transition period, the distribution period, when people are getting their cards. That's a whole year, and it's going to be very randomized. So if I'm John and my wife Mary, you know, already got her card, but it's 6 months later, I still don't have my card. Someone calls me on the phone saying, hey, John, I have your card. You know, can I send you an application, or can you just give me your old card number? I'll give you your new one over the phone. John's going to be antsy. He wants to get this ball rolling. He feels like he's behind, even though he's just not randomly been distributed his card yet. So that's some of the confusion we foresee, is our sister or our neighbor or our lady in our coffee club already got her new card, and I haven't. You know, and that's what we really feel the fraudsters are going to be preying on, is that type of a scenario that people want to get things going. So what we have done is we've created this wrap card, because another major concern of ours is Medicare does automatic deposit for their beneficiary checks. And we foresee that maybe there are a lot of outdated addresses out there. Perhaps people have not updated their address with Social Security in 15 years because they have been getting their check every month. You know, they don't care. What we're telling people is, if you do not have your Medicare and U-Book, if you didn't get that in the mail, you're not going to get your Medicare card in the mail. You need to update your Medicare information with Social Security. And Social Security will tell you the best way to do that is to go onto their website and create a My Social Security account. Has anybody in the room done that before?
Yeah.
Is that easy?
Yeah, it's easy to do, but
It was not easy for me.
I forgot the
Yeah,
password thing, and then that's a whole thing.
The password is a pain, because it can't be anything, or you have to create a unique username, which is not your name. So that's weird. And then it asks you to verify financial records from a long time ago, maybe the 90s, the 80s. Who did you have your mortgage with? Well, geez, that was bought out 4 times when I had my mortgage. So setting up those accounts can be kind of a pain in the rear. So this is what Social Security is encouraging people to do, is to go into My Social Security and create an account. And you do that through SSA.gov. Yeah, exactly. And then, but you could just ask them to go to the Social Security office to update it, or give them a call. But that's kind of a pain too. So that's one thing we do foresee being an issue. That's everything I can think of. Debbie or Tammy, does anybody have anything to add? Okay. But that's going to be a big deal. So what do they look like? This is new as of this morning. I snipped these slides. So if they're blurry, it's because I didn't have time to find a new picture. The current card, as you know, looks like this. It has name, the claim number, which is in the same format as Social Security with a letter following, their sex, when they started their Medicare Part A and B, and a signature line. They have taken away some things. It's still the name, the new Medicare number, which you see how it's listed here. It's very different. It's 1EG4-TE5-MK72. And then it's when they have issued the effective date of these things and no signature line.
So there's no way to identify that new card, like if it's A, B, H, B, C, whatever, right?
Yep.
You'll never know. Right, that's us.
But the date they're gonna show on there, that's gonna be the date the new card is issued versus the date their Medicare started?
No, it's going to be their entitlement date.
It'll
Good
be the-
question.
okay.
Yeah, when they signed up for Medicare. So it could be in the 80s or whatever. Yeah. Yep. Really good questions. And we have a lot of questions. We have been asking CMS to give us, I want a sample of what's coming in the mail. I want to be able to show you guys so you guys can tell people and our people can show people what to look for.
So they know
But
it's
they
not
don't want to
stamped.
say
Right.
Rapid City, you're getting your cards this week, because
Right.
then there'll be people shopping mailboxes. So they've got to make sure things are done just right, and I hope they do communicate the packaging, because a lot of people throw that stuff away. All right, so the supplements, this is kind of, we've already talked about this last year. The supplements, there's some changes to that. As you probably already know, Medicare Parts A and B don't cover all of the healthcare costs, so it's usually 80-20 of the coverage. So that 20% can be quite a burden for people to carry. So a lot of people want to pick up additional insurance coverage to help make that 20% a lighter load for them. And the Medicare supplement plans are changing slightly. They're removing plans C and F from the options that are available for anybody who enrolls in Medicare after January 1st, 2020. So there's still an option for anybody who enrolls in Medicare prior to that date, but they won't be available after that. So, because what they're doing is they're getting rid of that deductible. So plans C and F, what they have in common is both of them pay for the Part B deductible, which this year is $183. So plans C and F cover that. And what the thought is, and it's a common thought in a lot of insurance companies, you may notice that your insurance plans have had higher deductibles lately, or a little bit of a deductible where maybe there wasn't one before. The thought process is on that is if somebody has a deductible, they're paying for those first dollars of healthcare costs. Maybe they're not going in every single month to get a mole removed or their throat swab because they have the sniffles. You know, maybe they're being a little more conscientious of those. I'm paying for that first 183. I'm not going to go in for something little. I'm going to go in for, you know, something if it's a little bit more of a deal. It makes them more invested in their health care utilization. That's the thought process for it, because I didn't quite understand why they would do that, but that's what is going on. So people who have plans F and C would be grandfathered. They'd be able to keep those plans. It is a state-by-state basis on if the high deductible plan Fs will be continued and grandfathered in. I'm not even sure where South Dakota stands at this day and time for that. So there's a common concern when you think about how insurance works and how the healthy people or the people without car accidents keep the prices a little bit lower for those that do have car accidents and need to actually use that insurance. So with healthcare, people are concerned that there's going to be no younger, healthier people going into some of these plans that people are grandfathered into. So some people are freaking out that the plans are going to become pretty costly if they're already enrolled in it. Now, do we want to stir the pot and cause a huge uproar and concern? No, but we have been asked a lot of those questions, and I don't know the answers, but that is speculative and probably a relatively good speculation of what could happen. But we don't want to stir the pot with that, but that is a concern that we have. Okay, MACRA also made a few other changes focusing on quality versus quantity. So before there is a concern that Medicare providers are issuing maybe some additional x-rays or lab tests or whatever to increase their reimbursement rate because they're providing more services. So what they want to do is try to shift from that to a more of a quality. It's comprehensive and it's thought through, and it's not based on trying to rack up the payment. Some things that they have done with this program is, well, the quality payment program. The first thing it did was it ended the sustainable growth rate. That's been some old news for a while now. What the sustainable growth rate was is it actually took the health, let's see here, I want to make sure I'm getting this right. Yeah. What it did is it used to be set up, there was a law back in the day that told providers they were going to have decreased rates to encourage them to provide more efficient services for the cost. So it was a decrease in their paycheck they were anticipating. As you could tell, that didn't go through very well. It never actually it never was put into effect. They kept saying, nope, we're not going to do that this year. Then they'd come up again. No, Congress would say, no, we're not doing that this year. Our providers are in uproar because they don't want decreased payments. Kept doing that, so they ended it. They just canceled that law. That was not working out. It would never go into place because providers weren't willing to work with Medicare considering decreased rate structure. So they ended that and decided we need to focus on quality than quantity. So they're working on new frameworks. There's actually a lot of different pilot programs out there that are trying to give providers an opportunity to improve their care for their patients as well as to be rewarded for good quality care. So they're trying a lot of different things. As you can tell, that's pretty subjective. I mean, that's hard to measure. It's easy to pay per item, but it's hard to pay per quality. And so they're trying to work on an appropriate way to do that. And they have a lot of great things, and there's a lot of providers on board wanting to do this. There's a lot of people involved in the pilot. Another thing that they're doing is for reporting, it's complicated and complex, like probably all of us in this room. We report on things, and it is. Well, providers are asked to report on multiple systems. So this is combining the reporting systems into one to make it more efficient for them and probably more effective too. They're probably gathering better data because it's less work on their end. So that was a few different things they're doing with this MACRA. Let's see here. So the demo post, this has been around since I started, and I know even a little bit before then. So there was some major fraud, waste, and abuse happening with durable medical equipment. There were people who were calling the 1-800 number on the TV saying, I would love to have a free monitor and I'll sign up for my diabetic testing equipment. Well, then what they get is they get their monitor and then they get a monthly shipment of diabetic testing equipment to their door in an unmarked box, no number to call to stop it. But Medicare is being billed for all these shipments. At the same time, they're buying their strips through their local pharmacy because they sell the ones that work with their brand or whatever. So it caused a lot of waste and abuse. Same thing with the scooter commercials. Free Medicare beneficiaries can get their free scooter by calling this number. Well, they waived the co-payment for Medicare and they just billed Medicare for it and people they got their scooter or whatever, even if it wasn't doctor prescribed. So there were a lot of changes with this abuse. And this has been, like I said, this has been going on for 5+ years probably now. And what they did is they decided in some of the high waste and abuse areas, we're talking, not South Dakota, we're talking Florida, California, New York, places where there's a lot of scammers out there trying to really manipulate Medicare dollars. They're putting in a pilot program, and they're still testing it out. But what they're doing is they're making it, first of all, that you have to be registered with Medicare to be able to bill Medicare for your durable medical equipment. And that's not just the testing strips or the scooters, these are walkers and back braces and all of that kind of stuff. Anything that would be medical equipment. And what they've done is they've had these bidding cycles where companies could bid to provide durable medical equipment in these areas. So they're doing they're combining the other bidding projects into one and they're rebidding. And this is pretty much outside of South Dakota. However, South Dakota has been impacted, and it was back in the day, it's been some time now, but for those who are diabetic and they are needing testing strips, they can get them from their local pharmacy. However, if they want them delivered in any way, shape, or form, they have got to go through a national service provider. So they have to go through a national company rather than their local pharmacists, even if their pharmacist could deliver them to their door. It is to take away any delivery aspect of it. That's one of the impacts in South Dakota. And it may make an impact here if you have areas where pharmacies bring it to one small community and then the people from the surrounding small communities come pick it up. I know that exists in northern central South Dakota where it's been a huge complicated thing for diabetics in those areas, but I don't hear as much from this area. So they're still working on trying to make that a little bit more efficient cost-wise for Medicare. Let's see here. Then there's the moon update. We remember maybe last year we joked and said Medicare mooned people in the hospital. And Medicare started being last year, I think it was March 8th of 2017, hospitals were required to give out a Medicare outpatient observation notice. So they had to give out a sheet of paper to anybody who was in a hospital due to being on observation status. So that makes a huge difference in not only how to bill Medicare, but the cost for that Medicare beneficiary. So starting in March of 2017, individuals who are in the hospital, but not an inpatient in the hospital, not being treated for something, but being observed so that their health conditions are not worsening or they're staying the same or getting better. So they're in an observation status. If they've been in that observation status for 24 hours or more, within those first 36 hours, they have to be given this moon notice. They have to be mooned by Medicare. So Medicare has to give that to them. What that explains is the cost differences. Okay, instead of being billed by Part A, where you would pay this flat rate, this flat deductible, you're going to be billed by Part B. You'll have that $183 deductible plus 20% of any costs that are going into this visit, making an outpatient stay much more costly. In addition to that, it also goes on to explain that if you're not an inpatient in the hospital, you're not going to be able to bill Medicare Part A if they send you to a rehab, a skilled nursing facility post that hospital stay. So an outpatient going to a skilled nursing facility is still going to be billed. Now I say that and I don't know, they would still be billed Part B and it'd be really expensive, right? I believe that. No, but not billed at all, it's out of pocket.
Yes.
Yeah.
Yeah, probably just
there's
the
no
therapy.
coverage for Medicare at all.
You're right,
Yeah.
yes. So it'd be just the therapy billings, but
Yeah,
not
no
the
room and
stay.
board,
Thank
right,
you.
right.
Didn't want to get it wrong. So, but if they were inpatient for at least 3 midnights, we know this language, especially this room, then they would qualify for Part A, the Part A portion for a skilled nursing facility stay, and then it would be billed there. So major financial differences. And so this notice is supposed to describe it, plus give them a number to call if they were to disagree with that.
I'm curious.
Status, yep.
That seems to suggest that they're Part B can be billed, if they're on observation. We've always kind of experienced that people, Medicare doesn't cover it hardly at all if they're on observation.
And that's, okay, so Medicare doesn't cover it hardly at all is probably a very fair interpretation of it's billed by Medicare Part B and they pay 20% of the stay. So they pay a rate
20%.
versus that 1,100, that number, that deductible for Part A, then they get that 20%, which is, it is probably a very great
And
amount.
And so like someone that's in the hospital on short stay observation, they can't bill for the medications they give you. Although like some people don't know this, but you can privately submit your medication bill to your Part D plan and it will pick it up.
Yes, that is
That's a
correct.
big deal too.
That is a huge deal, the medication thing, you know.
$2,000 bill.
And does a hospital let you bring in your own? No. You know, they don't let you self-administer your own medications. They want to pay you, and those medication costs are exorbitant, you know. But you're right, if they do bill it, you could submit them to your Part D plan and have them pay. But you run into things, like maybe they've already filled that 30-day fill, and they don't want to pay it again. You know, there's a lot of hiccups that go along with that.
I used to help people when I worked with long-term services, and yeah, you had to write appeal after appeal, or it
Yeah.
was too long, or they didn't know that it wasn't covered, you know, it's a whole.
Very complicated appeals yeah, it is a headache. It's a huge deal, and does this solve the problem? No, but it at least starts some communication. It's a start to this. I don't think we're gonna end here. It's still too confusing, it's still too expensive, and it's tough. It's a tough situation for people, and it's common too. It's a common problem. So then there's Medicare Advantage. So they have been working on trying to improve the situation of Medicare Advantage plans. First of all, just to talk a little bit about Medicare Advantage plans. So Medicare Advantage plans, from the consumer standpoint, they're sold relatively lower premium than other Medicare options. A lot of times there's dangling carrots like, oh, we provide dental or vision or hearing coverage or silver sneakers. You can go to your YMCA or whoever participates with those programs. But there's a lot of incentives that entice people to enroll in those plans. But what you find out once you're in that plan, maybe you have some health conditions, is, you know, it's not maybe the best situation for me because, yeah, I'm paying a lower premium, but then everything out of my pocket when I have something spring up is way more expensive. Or maybe that dental coverage was a joke and not really worth my money. It wasn't worth me enrolling in that plan. All of that goes into consideration. Plus, Medicare is saying, these people are paying way too much out of pocket. These out-of-pocket caps are unrealistic. They aren't even, they do not cover people well. This is not what we're looking for. In addition to the fact that Medicare is paying these Advantage plans to take on the risk of insuring the Medicare beneficiaries. So for each Medicare beneficiary that's enrolled into, let's just say, a Humana plan or a Medica plan, whatever the plan is, it's an Advantage plan, Medicare pays that plan $850 to $950 per person per month that's enrolled in that plan. So that's the reason for the lower premiums. They're being subsidized by Medicare to take on the risk of insuring these people. So these plans are getting that payment, and Medicare is saying now that they've been around for quite some time, they're saying, you know, we are subsidizing these Advantage plans with original Medicare. It's costing us more to outsource this risk to these plans than it is for us to insure them on our own. We are providing care for cheaper. It's cheaper than $850, $950 for us to insure them ourselves than to outsource it to these plans. So that's where these changes are taking place. The dollars don't make sense, and you know they're trying to fix that. So what they're going to be doing is they're trying to make things a little more safe. So they're not going to permit cost sharing for the first 20 days of skilled nursing facility care. So what they're asking these plans is to mimic Medicare a little bit more. Make it where these first few days are similar to what Medicare is cost-wise. And so when people have a short-term stay in a skilled nursing facility, it's not costing them an arm and a leg. Also, same thing with those the cost share for days 21 through 100, they still can't be greater than original Medicare. So they're trying to put a damper on some of that extreme pricing. And then for all of skilled nursing facility care must be actuarially equivalent to what original Medicare should provide. So we're going to be noticing some cost decreases for Medicare beneficiaries who are being put into skilled nursing facility care. What we're also the cynic in me, I'm trying to always think from every angle, because you don't just give somebody the federal government can't just say, hey, plans, you need to sit down these prices and lower them. They have justified their costs elsewhere. So we're going to probably see some increasing in other areas or premium costs. You know, we're going to see, this is going to be a teeter-totter thing. There's always a give and a take. So we may see some of that with always when there's some regulation put into place. Let's see here. Same thing for chemotherapy, skilled nursing care, renal dialysis. They can't charge higher costs than original Medicare. They don't want people in unfortunate circumstances to have to pay big time for their situation. This is a chart that makes me want to go crazy. But what this is saying is the out-of-pocket maximums for these plans, they're also trying to encourage them to lower those amounts. Medicare wants to get more bang for their buck. If they're going to be paying more, they want their beneficiaries to be covered better. So that's what's happening there. One thing that's frustrating to me is plans, CMS allowed this for a very brief moment of time until people like our SHIP programs were up in arms saying this is horrible for people. What happened is Medicare allowed for a little bit of time people who sold, or plans who were selling people, let's say employer insurance or marketplace insurance or an individual type insurance prior to Medicare eligibility. They would be able to Medicare allowed them to seamlessly enroll, so without any hiccup, enroll people into an Advantage plan. So let's say if Humana covers somebody, I'm going to use them as an example, they probably aren't even a good example, but Humana had an employer plan with someone, they could seamlessly enroll them into their Advantage plan. You know, and it's a huge difference. These people should be probably shopping around. So Medicare said, hold up, we're not going to allow any more seamless enrollments until we figure out how to do this properly. So that's something that never really gained too much traction because those who were advocates for people on Medicare said, hold up, this is not that ideal for these people. So this was not included in the slides, and I think this is really important for our state in particular. There's a law that went into effect, and it will be effective January 1st, 2019. So we still got another year, but I think it's important to keep an eye on this because it's out there and these plans are aware of it. They're asking Medicare cost plans, which is a huge part of our Medicare Advantage market in the state. These are our Medica plans. We don't have any other cost plans but Medica cost plans in South Dakota. Medicare is saying, or CMS is saying, that cost plans need to be discontinued in areas where at least 2 competing Medicare Advantage plans that have a decent amount of people enrolled in them are available. So that means that we're going to have cost plans leaving South Dakota, at least in certain areas, in 2019. And what I really foresee, if I think through it, is I foresee Medica just turning into an Advantage plan, and just statewide, everybody's coverage is going to change some. Do we know what that looks like? No, I have no idea what that's going to mean.
Can you describe the difference between the Advantage and the cost?
That's a really good, yes, I will. That's a really good request. And in the manuals, I have a lot of information on this in the Medicare Advantage tab. But the difference between a Medicare Advantage plan, which are the PFFS, PPO, and HMO type plans, those plans that have networks of providers, there's a variety of different qualifications for them. We're going to go back, I'm going to give you full picture. So they get that $850 to $950 amount per person per month to take on the risk of insuring people. But beneficiaries who are enrolled in those plans, they have to work with the plan by utilizing the network of doctors, providers, if they have their own drug plan, they have to utilize that and the formulary that exists with that. And it's very dependent, there's a lot of caveats to that even. This is in a nutshell, and it's, nothing in Medicare fits in a nutshell very well. So those plans have all that. Well, Medicare cost plan, and they allowed this to be an alternative a while ago, and I can't even remember, I think these started springing up around when I started, probably 5 years
I was
ago.
gonna say, yeah, I think they were maybe for 5-year kind of a trial period.
Yeah,
so
I think
we're
that's
seeing the
what-
end of it now.
Yep, I think that's what we're seeing too. So what Medicare cost plans do is they say, you know what, you don't have to be enrolled in Medicare Part A, that's one of the things. So those who don't meet the Social Security requirements for the 40 quarters of service, these are kind of appealing to them because they don't have to have Part A, they don't have to pay that high premium if you don't meet those 40 quarters of service. Also, though in those plans, they can freely enroll and disenroll in cost plan. Does it mean you can enroll and disenroll in your Part D coverage? No, that has that open enrollment or the special enrollment criteria that it has to meet. But you could, at any time, if you wanted to enroll in a cost plan, you could, and if you wanted to get out of it and go back to original Medicare, you could. There's a lot of things to consider in doing those transitions, but that's one other thing. Another thing about Medicare cost plans is, yes, they have a network of doctors, providers, they have negotiated rates with these folks, these organizations. However, if you go outside of that, you could be just billed with Medicare Part B, so you pay that 20% then. Which could be pretty high cost if you get sent somewhere and they aren't part of that network, it could be a really high cost thing. But for a while there, these cost plans were really flexible and really appealing to our Medicare beneficiaries. We have a lot of people enrolled in them. And, you know, a couple years ago, it started out where we had agents, people selling these cost plans, telling people, just sign up for the lowest cost plan, and then when you need new glasses, you can switch to the higher cost plan, get those benefits, or let's say you're anticipating a knee surgery, switch to the higher premium cost plan for a little while, then switch back. They were selling it that way. Well, we had CMS coming doing a presentation. We're like, this just confuses us because insurance can't really operate that loosey-goosey, you know, you have to have the lower cost people in, it just doesn't work that way where you could easily pick and choose that kind of thing. And they were like, we had no idea this is going on. So then we've been noticing some marketing changes in our state anyway. So I think they put the hammer down on that whole, you can move here and there. But anymore, Medicare's finding, I think, that these cost plans are just not all that feasible, and they're hard to regulate and that kind of thing, but they're very popular. In fact, there's 900,000 Medicare beneficiaries on these cost plans in the United States. Minnesota has 700,000 of them in their state. Huge deal in Minnesota. And I'm very interested to see how they're gonna go about doing this in their state. But they have a lot more Medicare beneficiaries than South Dakota, our 162,000 Medicare beneficiaries. But we have I guarantee we have a decent percentage of ours that are on these Medicaid cost plans. So I'm just interested to see, first of all, what plans are being offered next year and how this is working, because we have a lot of states that only have the cost plan as an option. So what's gonna happen, I don't know, but I'm very interested and I'll be monitoring it. Yep.
Do you think with all these changes, it sounds like the private insurance companies aren't gonna necessarily make as much money with either, you know, like you were talking about the Medicare Advantage, they can't charge more than the regular Medicare rates and all that kind of stuff. Do you think we'll see just less Advantage plans in general, like will they just pull out?
We could see some cost changes, maybe they're increasing premiums, or maybe they'll charge a little bit more for your primary doctor visits, that kind of thing. We might see some just flux and changes. In our state, we started out with, Debbie knows us the best, we started out with a ton of Advantage plans in our state when they first, you know, when it was first getting traction. And then they continue to pull out. And a lot of that is because we don't have much competition in our state for medical providers. You know, what are they negotiating with? regional and regional. And, you know, I mean, there's not a lot of competition to do bargaining on pricing. So they're not having that advantage of negotiating power. Plus, we don't have the population to support massive enrollments in any plan, really. So we've had over time a lot removed from our area. Sioux Falls does have our largest amount. I'm sure it's a lot because they have the competing Sanford Avera and some specialty clinics. I'm sure they have a little bit more bargaining power, but we do have a dwindling amount in our state. Do you have anything to add on that, Debbie?
I remember when the cost plans came out, they were a real nice answer for those folks on disability. Because if somebody goes into Medicare on a disability, they can purchase a Medigap supplement, but the prices are considerably higher and often out of reach. And so the Medica plans would bring them on, and then they wouldn't have that 20%, they just have a $10 doctor copay or whatever. And so they were a really nice fit for those folks that were new to disability or new to Medicare because of a disability, and they couldn't afford those higher prices. But what I feel like, and honestly, before we even heard that they were changing, it was like you could sense it. You've been doing this for a while, you can sense the plans changing, and it makes you wonder why. But it feels to me like Medica is moving, positioning. They knew when they came on 5 years ago that the clock was ticking long before we did. And I have an idea they had probably had a business model, and they still do, where they're going to, like Jamie says, maybe roll over into a Medicare Advantage or something. Last year during open enrollment, one of our busy things was folks that were on Medica, the plan that everybody liked the most, I think it was $79 a month, but hospital stays were zero from day one. That changed to $100 daily copay. And that made our phone ring quite a bit at our office because they're like, well, my Medica plan now, you know, we're going to have to start paying $100 a day, and I don't like that, I'd like to find something else. That change by Medica, adding that $100 deductible, felt like another step towards complying with whatever this is going to look like here in another year and a half or so.
Yeah, and so this is not getting a lot of traction nationwide. This was not part of this PowerPoint even, but I foresee it being something that we need to at least start putting the feelers out. So you guys at least know, oh, this, I should either call Debbie and find out where we're standing with this situation, or I should you know, learn more about it. And we'll be continuing, next year we'll have more update to this. But there were, at the training where I learned about this, I was asking a lot of questions about it because it wasn't in any of the things, and they didn't give me hardly any information at all. What I have for research here is what I've just done on my own. So we'll keep you updated on that.
The insurance reps also didn't know. I was in Spearfish, I don't know when it was, about a month ago or so, and they were like, yeah, we're waiting to hear, you know, that the insurance reps know, but they can't really talk about it right now, what those changes are. But I think I'm anticipating when we can see the plan landscapes and start digging a little deeper into those plans here shortly, that we'll be able to see another maybe step towards that from Medica. The plans that we knew them 2 years ago are going to look less like a cost plan and perhaps a little bit more like a Medicare Advantage plan. So
yeah, we're still kind of blind in the dark with it. These are the counties, when I dug into each county, what had 2 or more plans, and I did companies was this, but there's a whole long list more that had 2 or more plans. They never really clarified this to my level of need, but there are at least 2 or more Medicare Advantage companies selling them. But as far as to me, what a plan would be is maybe Humana has 3 different plans that they're offering. Well, that's an Advantage plan to me. So if there's 3 Humana plans, does that mean the Medica cost plan has to go away? That would extend this list by almost every county in our state, almost everyone. Okay, so there's some updates to Medicare Part D, mostly to improve safety and then also to try to work through some waste issues that are out there. So we talked about this, I remember last year, where they are allowing Part D plans to issue, for some temporary type medications, to issue just a 30-day supply. So let's say I go in and I'm trying to, and we're going to try, I always just use so when I have a baby. When I went in to have a baby, I got some pain medication. They just gave me a 30-day supply. They didn't give me a 90-day supply. They just gave me a more temporary dose. Maybe this could apply with, maybe I'm going in for my first time kind of experiencing some allergies. Maybe they're gonna give just a trial, or I'm just trying to think of something else that may, but I think pain medication's a good example of this, but where they're allowing the plans to say, your first issue is gonna only be 30 days. From then on, if you still need it, we could do 90 days then, but just to prevent some waste in medication, and also some health issues that could happen if you had a larger supply and didn't need it. We're gonna stop that. So they can still do this 90-day afterwards if needed, but that's kind of discretion on the plan and the provider then. Also, what another change is that plans are going to be communicating with the people enrolled in their plan if they add additional formulary drugs that are available mid-year. Very interested to see what this communication looks like, because I can only imagine people getting a letter every other day saying, we now have this prescription on our formulary. I'm thinking it has more to do with ones that are similar to the ones they're taking. They would let them know, but it's just kind of interesting to me. I don't know what that communication looks like, but they're gonna be informed, keeping people up to date on changes in the drug list that each plan offers. So another thing that's been changing is the whole tiering of prescriptions with a plan. So plans have been allowed to label where a prescription falls. There's tier 1, 2, 3, 4, sometimes 5, then sometimes specialty medication. So, and it's really the plan's discretion to say where these are falling. Maybe there are some generics that are at tier 4. Maybe there's a name brand that's tier 1. You know, it's really the plan's choice to label where these prescriptions are falling in these tiers. But the tier plays a big factor. It determines the price of the medication and maybe even some of the restrictions that are out there. Maybe if they need to be approved by a doctor or that kind of thing. There's a lot of ways that plans use the tiering to structure who's enrolled and that kind of thing in their plan and the limitations. So I feel like I never adequately explained this as well as I should, but the plans are just needing to follow more of the federal guidelines on as far as labeling the tiers. They're trying to get a little bit more consistency with that so that it's less confusing for consumers. But Debbie, you always have a lot of good information to add on this. Do you have anything for this slide?
Sometimes you have those clients that aren't gonna change plans. This is when I hear about this the most. They're like, well, you know, I called and they're gonna cover this drug, even though it's gone up, everything else is still covered. It's maybe kind of an odd drug and not a lot of the plans cover it. And you can call the plan and actually ask them to continue covering it at the tier. They don't put that information out there, but I often will encourage, if you've got a client with a long med list and your plans are limited that cover every one of those meds, and they're on one that's working real well, but they've tiered one at a different level and it becomes too expensive, I encourage my clients to give them a call and say, listen, I've got a lot of meds, you guys are covering them all nice, can I get a tiering exception on this med, and then they can tier it lower and continue to get it maybe at a better price. But I've learned over the 8 years that I've been doing this more and more to encourage clients to talk to their plans if there's any issues, because more and more there are more issues. So, but that's one of them.
Are they willing to work with them?
I heard about it before, from a client. And I'm like, really, they'll do that? And then I started suggesting that, because that's where a lot of the stuff will never hear about it from those plans. But then the clients will say, yeah, my doctor called them and they said, yeah, because of my situation, they're gonna continue to cover that drug. Even if they've dropped it off of their formulary, sometimes they'll do that. So some of the stuff that I hear is pretty surprising. A lot of times the easy fix is just to find another plan. But if you're in a complicated spot where there's not a real easy fix like that, then I suggest, with a struggle like this, I would suggest you call that plan. I suggest it to the client. The plan doesn't want to really talk to us. You probably all know that. But and the client can call, and a lot of times they will. It's part of that. I think that in my mind, over the years I've been doing, it's part of that star rating. And so if they can, one at a time, do that, then that helps their star rating, because they're willing. If you go on into the site and you see that star rating, you click on it, that's part of it, you know, their willingness to work with exceptions and stuff. So, that's always, and when I see this slide, that's what I think of.
Yeah. Interesting. We're all learning new things. Specialty tiers, yeah, so it goes into what Debbie's saying here, for people being eligible for tiering exceptions, that kind of thing. I think they're still trying to work out that 5-star rating thing and trying to encourage plans to be a little bit more flexible. And they're also, they're concerned about how plans are labeling specialty tiers. This is kind of touchy. So in the past, the specialty tier was listed at $600 per month per refill or whatever it would be. But they're increasing it they did for 2017 and now again for 2018, it's $670 per month per medication. Anything at that threshold needs to be labeled as a specialty tier. So they're just giving them some guidance on that tiering once again. Then there's the whole opioid overutilization. I'm going to start out with some South Dakota information. And in South Dakota, we are not exempt from the opioid crisis. And we knew that. We know it exists in our communities, but I wanted to make sure that I looked into it a little bit so that you guys can understand that it does go on in South Dakota, and I just want to make sure I do this. So in South Dakota, these are some of the things that I found interesting. So in 2014, we saw 37 deaths due to opioids, which are pain medication related deaths and addictions to that. In 2015, there were 65 deaths, so it almost doubled in the year after this. And I don't have any data beyond that. But just to give you an idea of what somebody who is affected or who is addicted to opioids, what they look like. And these are just deaths. These aren't hospitalizations or overdoses or even just quick check-ins. These are people who actually passed away due to it. About 50, it's almost close to 50-50 for males and females who are addicted to this, to opioids. And 82.4% of our people in South Dakota who were addicted are white. 16.8% are Native American. Now that is about the same percentage of Native Americans to white, so it's about evenly impacted, I think, for the populations that are out there. So it's not just a tribal problem, it's everywhere. And what interested me a lot is the related deaths are from the most highly susceptible age range is 45 to 54. That's the age that is most often affected by this. Next being age 25 to 34, and then after that 35 to 44. So those age ranges are really surprising almost to me. I had to take out a few different slides that were there, but hospitalizations, I mean, there are, from the period of 2006 to 2014, there were over 2,500 hospitalizations due to drug overdose to opioids. And that's overnight stays, that's not the inpatient.
So it's interesting now those numbers are like 65 and older.
Yeah. So, and it still exists in that, it's not as, that's our South Dakota stats, and I had to go into Department of Health's thing, so they were really focusing on they were just focused on the trends in our population. But it is a problem in the Medicare world. I mean, it's Medicare beneficiaries, those who are elderly and disabled, they are not exempt from this problem. And Medicare is trying to do its part to help do their part in this crisis, to try to alleviate the impact of not only the addiction, but also the deaths that go along with it. So I just wanted to give you a little vision that, yes, it is in our state too. You know, we're not rural exempt from the problem. Part D plans are encouraged and are really mandated to provide controls at the point of sale. So at the pharmacy, people could be rejected their medications, or there could be an audit right then and there prohibiting the sale of an opioid if they meet certain criteria. The suggestions from CMS are multiple providers, so we're saying 3 or more providers prescribing opioids, 3 or more pharmacies issuing opioids. These are heavy users. These are people who could potentially be working a system, you know, and going to multiple people to get their pain medication, then multiple pharmacies to spread the problem a little more, you know, spread their evidence, I guess, a little more thin. However, a big deal with this is that the therapy, if for those who are addicted who want to recover, the therapy that's suggested is medication-based. So they're prescribing different pain medication to treat the addiction. So they want to make sure, CMS is very concerned that the therapies aren't affected by some of the audits that are out there trying to prevent or trying to stop the problem. So the medications that are used for therapies are exempt. There's a lot of controls that go in here, and it is I'm sure, a work in progress. And they want to make sure, the CMS is making sure that the prescription drug plans, they have to cover the medication therapy, the traditional medications that are used to help people recover from their opioid addiction. They're mandated to cover those prescriptions on their formulary. And then there also can't be too much restrictive utilization. So they can't do the prior authorizations, the step therapy. They have to make sure there's limited hurdles for these people who are trying to recover. So they want to try to make it easy, cost-effective, and hopefully successful for these people who are trying to overcome their addiction. So that's what I have on opioids. There's been something that's been in our training for, I really think, the last 5 years that I've been doing this, but they've been trying to put into place where the people who are prescribing medications, the prescribers, have to be registered with Medicare. They've been wanting to have that mandated, that registration with Medicare mandated for a long time, but this date keeps moving. So now it's January 1st, 2019. They must be struggling getting this enrollment thing taking place. So what we're finding is it's not the doctors. The doctors are registered with Medicare. It's the things like the dentist, maybe places that would be prescribing some medication, but not traditionally enrolled with Medicare, because they can't bill Medicare in any other capacity, but they may need to prescribe medication that would be billed through their Part D plan. They don't, at this point in time, it's not mandated they're registered, but they will need to be by January 1st, 2019. And we'll see if that date moves. But I was told at this last conference, it's not going to move. But I was told that the conference before that too, because it's already moved like 4 times. So, but anyway, they're trying to provide that safeguard. They're trying to find out who's prescribing what to who so that they can help it's, I'm sure, a lot to do with the opioid crisis. It's trying to figure out who's prescribing what, where are these trends coming from, because their data is just an immense amount of information that's out there. So they're trying to put some analytics to this. So what CMS is also doing is plans, Part D plans in particular, that have low enrollment numbers, they are encouraging plans that have fewer than 500 enrollees to withdraw from the area. We may see an impact from this. We have very few people in our state, but they are asking them that if there is not a sufficient amount to just not renew. They're not allowing them to renew. So, and anyone that has any standalone plan that has less than 1,000 people enrolled in it is encouraged to consolidate. So we may see some changes here due to this. What they're trying to get at here is you cannot cost effectively run an insurance company if there aren't enough people enrolled. You're not able to keep the costs, and it's kind of conflicting with, you know, they want to make sure that these companies are not belly up at the end of the year kind of a thing. they wanna make sure there's enough enrollees to keep it solvent, financially solvent. So they're trying to work on this in this way. There's the whole removal of the donut hole, that closing of the coverage gap. This has been around since the start of this was part of the Affordable Care Act. And we're now in year 2018, you know, and of course there's a lot of change. The Affordable Care Act is like a swear word in the news these days, but this is a major impact with Medicare that was associated with that particular law. We're now where, as they're closing the coverage gap, a consumer would pay 35% of brand name drugs and 44% of generic drugs. This used to be 100% during this gap that the plans never did. So this is a significant savings right there. But what the goal is to reach 2020 where everybody would pay 25% of their medication costs there would be no more donut hole. Because you pay 25% of your medication costs in the initial coverage period. So it would remove the donut hole entirely. Does that make medicine free? No. It makes it where there's not all the volatility through a plan year. It makes it where, yes, you may have a deductible, then it's initial enrollment, then there's the regular part until the catastrophic, when you hit a certain dollar amount, which is nearly $5,000 right now, then you pay 5% of the medication cost once you hit that amount. But that's what it will turn into eventually. Just depending on the situation. Things could change, but this is where we are now for this year. The 21st Century Cures Act was, let's see here. So they're going to delay the authority to terminate contracts for Advantage plans if they meet minimal star ratings for their plans. So they have, with Part D plans, they have been terminating or suspending those plans that have not been providing great customer service or achieving those 3 or more star high star ratings. So the Medicare Advantage plans, they're still trying to figure things out. I'm sure it's difficult to assess quality in the variety of ways that they're doing, but there's a delay in it. And it's only my speculation where I even would guess that, so. But another thing that they're doing as part of this particular law is they're updating the Welcome to Medicare packet, providing more clarification on Parts A and B, as well as supplements, Medicare Part D and Advantage plans. So they're gonna hopefully include some more information. We were able to look at it or provide feedback on it, but I have not seen the new packet yet. Another thing that they are doing is they're adding an opportunity for those who want to have a Medicare Advantage plan to change coverage. So January, February, and March, people in Advantage plans can enroll into those plans during those months. Now, plans can't market during those few months, but I'm very interested to see this, and it actually caused an uproar in the national training that we were at, because people were like, why don't we get this for Part D too then? You know, why is there just an extra opportunity for people to enroll in Advantage plans or make changes, but there's not for Part D? So,
Because in 2009, they could do that, and it went away, and now it's back.
oh,
Did you hear that at the national?
no, I didn't.
Yeah.
Until
So when I started, the Advantage plans our open enrollment at that time was November 15th through the end of the year, I think, for those of you that have been here a while. So the Advantage plans had from November 15th through March.
oh,
That was their open enrollment. And then it felt like, but I was pretty new, along with the Affordable Care Act stuff, it got squeezed down to the open enrollment with the Part D.
okay.
I remember thinking, well, now this is gonna put a target on the back of our low-income people because they can enroll anytime. And it kinda did, honestly.
Yeah.
But yeah, I find it interesting that now it's kind of, they're gonna have that gap between December 7th and the end of the year, which they didn't have in 2009. But in 2009, an Advantage plan had from November, for as long as they carried drugs, they had the Part D open enrollment November 15th through the end of the year. And then their Medicare Advantage open enrollment started January 1 through the end of March. So they had a nice little long open enrollment.
So I'm sure we're gonna definitely have more information at next year's training about this, but yeah, it's interesting. It just kind of makes you raise your eyebrows a little bit. And also, one thing that they're adding is Medicare Advantage plans can start covering people with end-stage renal disease starting in 2021. That never was an option before, and now they're able to. And what Medicare will do for those with higher cost diagnosis is they will increase their reimbursement rate for them to take on that risk. So we'll just see how that plays out too, if they take that on that risk. So we're near the end here, but this is just showing you the different ways that they're trying to they're trying to fine-tune their payments toward quality versus quantity. So they're trying to reduce the growth in expenditures for Medicare. That's one way they're trying to cut costs. But they're trying to do hospital payments based on performance. They're also bundling a lot of different things. There's a lot of places that are trying different ways. We're working with CMS on different ways to provide billing. There's a lot of people, a lot of organizations participating in the pilot programs. There's also ways that they're trying to encourage clinics to look at these alternative payment models and providing financial incentives for them to do this. So there's just a lot of pilot things going on. There's nothing official on how they're doing this, but they are very surprised at the level of involvement. They expected 35% to be participating by the end of last year, and I think they exceeded that. And they expect 50% of providers to be participating in some form of a payment model by the end of this year, I believe, is how that's working. I'm just going to do the main highlights here, but the 4 main goals of CMS is to provide better care and lower costs, to do prevention and population health. So they're trying to just encourage a general healthier population of Medicare beneficiaries. They're trying to expand coverage available, and they're trying to encourage the enterprise as a whole to provide better quality and diverse workforce and innovative strategies. They don't want to stifle the ideas for growth and change and betterment either. So they want to continue to collaborate and encourage these organizations to work with them. So, this is the details on that. Yeah, they're surprised at how many of the clinics are going to be participating. And oops, I said 35%. It was 30, and now they are at more. Maybe they are at 30%, but they're very excited about the willingness of the providers to work with them. And I swear I hid these slides. But so when they're working on these things, they're trying to really improve, in particular, some main areas of concern. The areas where Medicare is spending a lot of money on their beneficiaries to have cardiac care, orthopedic. We're looking at hip replacements, knee those kind of things. They're really focusing on these areas for trying to find these alternative payment models. And they're also trying to find different ways to encourage the smaller practices, the smaller entities to participate with Medicare and encouraging them. So there's a lot of different things going on. And that's the end of these updates. Does anybody have questions on that?